A very good evening, a very warm welcome. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session on drug dosing and dialysis by Dr. Varun Kumar, sir. I'm thankful to all the participants from all over the country who've taken out their valuable time and are attending this evening talk. Pharm D Community has been created with the charter to provide free webinars by doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate, and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible without the wholehearted support of my core committee members. Thanks to Kuldeep, Pooja, Vaishnavi, and Yamini. I would like to wish everybody a very happy Diwali. Also, I'm very thankful to our speaker for today, that is Dr. Varun Kumar sir, who is one of India's eminent nephrologist. I'll hand over the session to my teammate Vaishnavi to introduce our speaker for today evening. Over to you, Vaishnavi.
Thank you, Aishwarya. I once again welcome all participants to the second day of our dialysis webinar. I'm glad to introduce our speaker again.
Vaishnavi ma'am, I think you already did most of it. You can just be brief with this. No need to tell so much.
Yes, sir. Sure, sir. Just for those who are joining us today. Sir has done MBBS MD in 2014 and was awarded a Student of the Year Award and Medal by Delcure Life Sciences Limited for year 2014. He has done DM in nephrology and was awarded Shri A. Salamuthu Udayar and Shri A. Salamuthu Udayar and Puvyamal Gold Medal for Best Outgoing Student in DM in 2017. So was also awarded certification in nephropathology by International Society of Nephrology. So was consultant nephrologist at Arun Kidney Center, Vijayawada, Andhra Pradesh. Sir is currently working as assistant professor and head of Department of Nephrology at Dr. Pinna Maneni Siddhartha Institute of Medical Sciences and Research Foundation, Andhra Pradesh. He is also co-convener at Faculty Research Club at Dr. Pinna Maneni Siddhartha Institute of Medical Sciences and Research Foundation. He is also a member of Institutional Ethics Committee in Dr. Pinna Maneni Siddhartha Institute. Sir is editorial board member of Clinical Medicine Research Journal. Sir has various memberships in International Society of Nephrology, International Society of Peritoneal Dialysis, International Society of Pediatric Nephrology, American Society of Nephrology, European Renal Association, Asia Pacific Society of Pediatric Nephrology, Andhra Pradesh Society of Nephrology. With this brief profile, I'd like to welcome our speaker for today, Dr. Varun Kumar Bandi, sir. Over to you, sir.
Thank you, ma'am. You keep giving two generous introductions with this. Okay. When I start today's presentation, I just keep it brief because last time I think dialysis itself was too extensive. So I try to keep this brief. Most of the drug dosings will be already to be covered. No, it will be just textbook by hearting. What is the GFR concentration of what, how much dose has to be given, that most of you will be knowing it is there in textbooks. So rather than going to other numbers, what we do is we just keep it to the, what are the basic principles that we use. What are the principles? So how do we consider the dose? Suppose we have a new drug, how do we know whether it has to be changed in dialysis or not? What is the effect of the kidney disease on this? Just brief on how to understand about drug dosing, that's it, okay? So this is the outline which I talk. First, introduction in pharmacokinetics. You are experts in that, which I'll be covering briefly about bioavailability, volume of distribution, and drug metabolisms. So what are dosing strategies which we can use in patients with kidney disease or dialysis, and what is the dialysis clearance? Which drugs? How do they get? How do we monitor for dialysis clearance of individual drug? And a brief note of the different commonly used drug categories which we use, which can be, which are affected by dialysis. So introduction, as you know, CKD can affect the, so any drug has to undergo through glomerular filtration After that, it can undergo tubular secretion and tubular reabsorption or bioactivation like vitamin D or metabolism. So all these things can happen within the kidney. In CKD, all these things are affected. And apart from that, the general drug absorption, that is bioavailability or protein binding. So all your pharmacokinetic profile is also altered in CKD patients. So therefore, we need to be extra careful when you're choosing a drug in these patients, because either the active drug per se or its metabolite can accumulate, which can cause either increased effect, there's exaggerated pharmacologic effect, or the toxicity. So we have to be more careful in dosing in these patients. So pharmacokinetics, most of you already know. So I'm much junior to you in this profile. So I just keep it brief about pharmacokinetics. It is a course of what does the body do to the drug. That's one part. So the parts in pharmacokinetics, first thing is the drug absorption, whether you are giving oral, IV, rectal, lung, how much of it is entering the blood. Once it enters, how much is staying in the blood or how much is going to tissues or into other fluids. So after that concentration is achieved, then what happens to the drug? How is it made? It is metabolized in the liver, kidney, or the GIT, then eliminated. So let us go through briefly one by one. The first thing is the bioavailability, the drug absorption. That's bioavailability. So it's the fraction of administered dose which reaches the systemic circulation. For IV drugs, because you're injecting directly into the venous blood, it's 100%. For oral tablets, it's variable depending on the individual drugs. So that has many properties which you know better than me in those things. So what is the effect of renal disease on bioavailability? So when you come to tablets, if you're taking for oral tablets, oral medications, what happens is it decreases the GI absorption. Why it decreases GI absorption? In CKD, the urea levels goes up. What happens to this urea? In the saliva, it gets the urea concentration in the saliva increases. So this gets converted to ammonia. Ammonia causes alkalinization of the saliva. So the pH changes. From acidic pH, it becomes alkaline pH. So for all the drugs which need acidic pH, like iron, the absorption is decreased because the pH is alkaline now. Then what happens once you take the tablet inside the gut, the bowel movements, that is called intestinal paralysis, the bowel movements, so they frequently contract and react. So that movement of the bowel is decreased. That is also again decreased absorption. So apart from that, what happens once the drug reaches the intestine mucosa, it has to pass through the mucosa. It has to get absorbed from the intestine. What happens here? The intestinal wall is edematous because of CKD. Fluid is freed over there. So instead of this thickness, the wall becomes so thick. So the drug cannot pass through so much thickness of fluid. So again, decreased absorption. Apart from that, many CKD patients are in phosphate binders. The main use of phosphate binder is to form insoluble complexes, especially with calcium. But it can also form insoluble complexes with drugs. We give a drug with the food or after food, these phosphate binders present in the intestine bind to the drug, form insoluble complexes, so they do not get absorbed. They are excreted in the feces. So again, this also decreases absorption. So these are the factors which decrease the bioavailability when taken by mouth. But after that, the first pass metabolism, what happens? In the liver, there is reduced biotransformation. So there are few components, and the conjugation is decreased, hydroxylation and oxidation are increased. Hydrolysis and oxidation are increased. So that depends. But conjugation is a major biotransformation which happens, which is reduced in CKD. So there is increased presence of active drug. It is not inactivated, especially in the hepatic. This is the hepatic biotransformation. It is inactive. It is not inactivated. So active drug concentration increases. Again, toxicity. And plasma protein binding is also affected. That we come to that how it is affected. So what happens once the plasma protein binding is affected, the concentration of free drug increases. As we know, the free drug is the one which is the active part. The drug which is bound to the proteins is the inactive part. So once this free drug is increased, that is taken up by the liver and causes hepatic, that the hepatic parenchyma metabolizes that drug to inactive metabolites. So this will again decrease the availability of the drug. So not in absorption, even the first pass metabolism is affected. So coming to the what happens in the blood, that is predominantly volume of distribution. So what is the volume of distribution in what happens to volume of distribution of different drugs? So it is the amount of drug in the body divided by the blood concentration that you will be knowing. So if there is high volume of distribution, that means the drugs are more lipid soluble, which are going outside the blood. They are either binding to tissues or they are bound to lipids. So in that case, the volume of distribution is very high. For water soluble drugs, the volume of distribution is very low. So this again is important when we're considering dialysis. That this determines how much of drug is removed in dialysis. So what happens for water-soluble drugs? Suppose patient has volume overload. So that means you see patients with CKD having edema, facial puffiness, fluid effusions, ascites, everything. Everywhere there is water filled up. So in that, what happens is water-soluble drugs not only in the blood. Suppose normal blood volume is 5 liters. Because of volume overload, the water, this thing can become up to 8 liters or 10 liters. So the same amount of drug, instead of getting distributed in 5 liters of blood, now it gets distributed in 10 liters. So the concentration comes down. The opposite happens in muscle wasting. When there is muscle wasting, the volume of distribution comes down. So the active drugs achieves higher concentration with the same dose. So when you're giving a dose, you have to carefully look into its volume overload status and the muscle wasting. Both of them are common in CKD patients. If volume overload is there, the same dose, patient will achieve lower concentration. If muscle wasting is there, the same dose, we achieve higher concentrations. So this we have to keep in mind. So then protein binding. The protein binding is a key determinant of volume of distribution. If protein binding is high, the volume of distribution is low. That means most of the drug is bound to the protein. The amount of drug available in the blood, in the water, in the liquid, dissolved in the liquid is minimal. If protein bound, high protein bound, volume of distribution is low, and vice versa. So these protein bound drugs are usually inactive, so they do not cause toxicity. What happens in CKD is this protein binding is affected. So if there is reduced binding, the amount of free drug is increased. This becomes toxic. So in CKD, first thing is because of malnourishment and inflammation, albumin goes down. The serum albumin concentration goes down. So obviously, once the albumin level goes down, the protein binding will come down. Apart from that, CKD is a state of acidemia where organic acids accumulate, phosphoric acid, etc., which get accumulated. These acids, they compete with acidic drugs for binding to albumin. So normally drugs bind to albumin, but in this, what happens? These acids come in the bind to albumin, preventing the binding of the drugs. So the drug concentration increases. This is commonly seen in drugs like phenytoin, salicylic acid, or warfarin, etc. These are acidic drugs. So their free concentration will increase. So if you measure the total blood concentration, it will be normal. But if you measure the free concentration, it will be high. So with the same amount of total blood concentration, patient we can develop toxicity. So we have to be careful in monitoring the free levels, not the total bound drug. And come to the acidic drugs. Now what happened to basic drugs? Basic drugs binding is increased to non-albumin proteins. So the free concentration comes down, the efficacy comes down. So for acidic drugs, there is more chance of toxicity. For basic drugs, there is less efficacy. So then drug metabolism, and so kidney, since the CKD end stage renal disease, kidney metabolism is not there. So it is what liver and GI. So these patients can have altered hepatic metabolism, not only from kidney. Kidneys anyways not working, but even hepatic metabolism, GI metabolism, everything may get affected. For individual drugs, there is difference. There is increase in oxidation, hydroxylation, as we are told, and there is decrease in conjugation, or some parameters remain unchanged. So it depends on the individual process happening. So there's the basics of pharmacokinetics. Now how will that help in dosing for a patient? How do we select the dosing strategies in a patient? So there are two dosing strategies. The first thing is the loading dose and the maintenance dose. For some drugs, we give a loading dose for drugs which are eliminated slowly. So what happens is, if you push a high concentration, you are maintaining a sufficient level, but afterwards, the amount of drug needed to maintain the threshold is minimal. So this loading dose is adjusted based on volume of distribution. It has no effect. The CKD has no effect on loading dose. So even with patients have creatinine of 1, that is normal enough function, or creatinine of 10, or patient is on dialysis, so loading dose will not change. Loading dose is not affected by the CKD status. Loading dose is affected only by the volume of distribution. Keep that in mind. It does not change. Any CKD patient, loading dose remains the same. How do we measure the loading dose? How much loading dose to be given for a patient? That you measure by target concentration, which you need to achieve, into volume of distribution, into ideal body weight for the patient, not the actual body, ideal body weight, divided by bioavailability. For tablets, bioavailability, you already have established pharmacokinetic studies, which you get from FDA. Or if it's intravenous, bioavailability is 100%. That is one. Maintenance dose is to maintain, once the loading dose takes the drug concentration to some certain point, afterwards you follow it with maintenance dose to maintain the drug concentration above the therapeutic range. So we have two options when you consider maintenance dosing, either in CKD compared to normal people. Either reduce the dose, either you can make it half or 1/4. So what does this? What this does is you maintain the same duration. Suppose previously you're giving 1 gram 6th hour. In CKD, we reduce dose, make it 500 mg 6th hour. So just reduce the dose, but the 6th hour duration is common. So there is more constant drug concentrations. But since the drug can accumulate in this, there is high chance of toxicity. The other strategy is increasing the interval. So instead of giving 1 gram 6th hour, what I do is I give 1 gram 12th hour or 1 gram once a day. I'm giving the same dose, but increasing the interval. So what happens when you increase the interval? The toxicity risk comes down, but there is high chance of subtherapeutic drug concentrations. So this increased interval strategy is used especially when we have drugs with a wide half-life. When the T-half is very long, either normally or some patients with ESRD, the T-half goes very high. So once the T-half is very big, in those patients, we consider this strategy, where increasing the interval is enough. If the T-half is not so big, then we consider just reducing the dose and maintaining the same duration. So this is how you decide on what dose to give. So this was it. Say, suppose this drug we have used a drug X. Its threshold for efficacy is 2. So what we do is first we give a loading dose. See, suppose you give 1000 mg of loading dose, you are taking the concentration above 2. Then afterwards, to prevent its fall, instead of giving 1000 mg every time, you can just give 200 mg. Just by giving small doses, you are maintaining the level above the therapeutic range. So that is the use of loading dose. You give a loading dose to take it up above the threshold, and then what it does is it decreases the need of maintenance dose. So the amount of dose which is required in maintenance period comes down. So that is the effect. That is the usefulness of loading dose. So examples. Okay, one of you who is active can try this, or you can put it in the chat box. So loading dose, we told it is target concentration into volume of distribution into ideal body weight divided by bioavailability. Suppose you have a patient with CKD on dialysis. He's on dialysis to Juga catheter. IJV catheter got infected. So the commonest drug which you use for IJV catheter sepsis is vancomycin. So how much vancomycin to give? Your patient on dialysis. So when we go through it as a vancomycin, each drug, we have FDA data based on the previous pharmacokinetic studies. So for vancomycin to reach the therapeutic effect, we need a target concentration of 20 milligrams per liter. And its volume of distribution in ESRD is 1 liter per kg with 20% protein binding. So 1 liter per kg is the volume of distribution. Ideal body weight is 50 kgs for that person. His half-life, normal half-life is 6 hours, but in ESRD, the vancomycin half-life can go to 150 hours, so very wide. So what will be the loading dose for this patient? Anyone? Anyone is active? You can either put it in the chat box or one of the 4 hosts, who is hosting the Pharm D community. You guys itself can take the case. What will be the loading dose?
Participants, you can put your responses in the chat box.
I think I have accessed. Is it 0.6? Okay, one of them gave 0.6. Okay. Any other options? See, target concentration into volume of distribution into body weight. Target concentration in this case is 20 milligrams per liter. So this is 20. Into volume of distribution is 1. See, this is in liters. So this has to be in liters. Body weight is kg. See, just make sure that all of them are same units. Liter, kg, kg. So you can directly put these numbers. Target concentration is 20 milligrams per liter into volume of distribution is 1 into body weight of 50. Bioavailability for injections is, I told it's intravenous injection. So bioavailability will be 1. So it's 20 into 1 into 50 divided by 1. Any doubts? Yeah, someone gave me answer of 1000 mg. It's like 20 milligrams per liter into 1 liter per kg of volume distribution into 50 kgs body weight. So that comes to 1000 by 1 is 1000 mg. So the loading dose is 1000 mg. As I told, the normal loading dose for vancomycin is 1000 mg. We don't, this vancomycin or any drug, loading dose does not depend on GFR. Does not depend on kidney function. It depends only on the volume of distribution. See, even the formula, we do not have any way about whether patient's creatinine is high, low, or whether patient is on dialysis. All we are interested in is volume of distribution. This is standard for all patients. Target concentration established by FDA, that is the concentration we need. Body weight just depends on body percent. So what actually influences is the volume of distribution. So 1000 mg is the loading dose. Now, maintenance strategy. What strategy do you want to use? You want to use a dose reduction protocol where you, suppose normal dose is 500 mg BD, sorry, normal dose is 1 gram BD or 500 mg TID. You want to use just reduce the dose with the same duration, or you want to increase the interval. Instead of giving twice a day, you make it once a day. Which maintenance strategy do you guys want to use? Anyone? The co-host? Okay, fine. Someone put dose reduction. Okay, let me just go back. Can you see this? Okay. So we have reduced dose or increasing the interval. When do we use increase interval? For drugs which have wide half-life, we increase the interval. For drugs with a shorter half-life, we reduce the dose. Okay. What has happened to half-life of vancomycin? I have not many slides, so I take more time on interactions. Okay. So you people need to be more active.
Increased, sir.
Increased interval. So with this half-life is high, so someone has given me an answer that increased interval. So in this patient, since 150 hours is a huge time compared to normal 6, so half-life is increased, I would go for increased interval dosing. So loading dose will be the same. And once it comes to maintenance strategy, I give the same maintenance dose as normal patient, but at an increased interval, because it has a wide half-life. So this is how you decide on a loading dose on a maintenance strategy in a patient on dialysis or patient on CKD, anyone. So then coming to dialysis clearance, fine. What does the dialysis do to these drugs? The important factors which we consider when you are considering the drug effect of dialysis on drugs is the molecular weight of the drug, the protein binding, and the volume of distribution. Molecular weight, diffusion. When the molecular weight is small, this I spoke in the last class. When the molecular weight is small, it is less than 1000 Daltons. Diffusion is enough to take care of that. But if the molecular weight is more than that, medium molecular weight, because 1000 to 30,000 Daltons is medium molecular weight. If it's more than 1000, diffusion will not help. In that case, we need convection. So it depends on which method you are using. If you're using diffusion for dialysis, we only small molecular weights will be removed, medium molecular weight drugs will not be removed. If you are using convection, then medium molecular weight also will be removed. So this decides on how to dose the drugs. Okay, fine. So I have one more question for you guys now. Which dialysis modality uses diffusion principle and which dialysis modality uses convection principle? We have hemodialysis, hemofiltration. These two I think I spoke last time. I don't know if you guys understood. Hemodialysis, hemofiltration. They are two different principles, two different methods of doing dialysis, hemodialysis and hemofiltration. You can combine them both. That's called hemodiafiltration. That gives you best of both. Both of them happen. So what method does hemodialysis use? What method does hemofiltration use? Based on that, you decide. Most of the patients on dialysis in India or across the world, most of the patients are on hemodialysis. Hemofiltration is expensive. Okay, so diffusion, someone gave me diffusion. Diffusion is for which method of dialysis? Hemodialysis or hemofiltration? Host? Anyone just give me a guess? Hemodialysis, hemofiltration. This is not a Viva OC examination. I don't expect all of you to answer. I just want attempts.
Dialysis, sir.
Good. So someone answered also. Diffusion is for hemodialysis. D for D. Diffusion is for hemodialysis. Convection is for hemofiltration. So if you are doing hemodialysis, we have to adjust to the dosing of small molecular weight drugs. Medium molecular weight drugs can be given as it is, no additional requirement, because medium molecular weight drugs are not removed by hemodialysis. So we do not bother about those drugs. Only small molecular weight drugs we have to bother about them, about increasing the dose or giving additional doses. But if you're doing hemofiltration, then we need to bother about medium molecular weight drugs also. This type of modality, we can do hemodiafiltration that combines both. So depending on what type of modality is used, we have to concentrate on the drug dosing. Okay. So protein binding, as we told again, if protein is dialysis, again diffusion convection is just nothing but pushing from one concentration to another concentration. That means most of it should be present in the water. If the drug is protein bound, high protein binding is there, then the amount of drug present in the water is minimal. Most of it is bound to proteins, or if it is bound to tissues, or it is bound to lipids. The amount of drug present in the water is very minimal. Only the drug which is present in the water is removed by dialysis. So if protein binding is high, does not get removed by dialysis. Volume of distribution. Again, if a small volume of distribution, they get digested better. Most of it is removed. If it has a large volume of distribution, removal is less because most of it is present outside the blood. Large volume of distribution is present outside the blood in tissues, in the lipid spaces, other spaces. So what we are doing in dialysis is only removing the drug which is present in the blood. So removal is yes. But what happens once you remove it from the blood, the other part in the tissues, everything starts coming inside the blood. So from outside it starts coming because blood concentration has come down. From outside the blood it starts coming inside. So from some fatty tissues, some drugs get deposited in the fat. What happens when doing dialysis? The blood concentration comes down, especially organophosphate poisonings, OP poisonings, all this stuff. What happens is, or pyracate poisonings. The drug in the blood, the drug concentration of the blood is reduced by doing dialysis. But the drug in the fat is very high. So after dialysis, what happens? The drug from the fat starts entering the blood again. That is called rebound. So removal is very minimal, but there is more rebound. Okay, one more question. Between water solubility and lipid solubility, which of them has a smaller volume of distribution? Which of them has a larger volume of distribution? Even the speakers can give. Okay, lipid solubility, someone answered. What is lipid solubility? Okay, I gave the answer. Fine. Thing is, if it's water soluble, they have a small volume of distribution. They digest more easily. If it's lipid soluble drugs, they have a larger volume of distribution. They do not get removed so well, and they are more associated with rebound. Okay. So who can tell me these four parts? If a drug has to be removed by dialysis, what should be the molecular weight? What should be the protein binding? What should be the water solubility? What should be the volume of distribution? For a drug to have increased removal in dialysis, you do hemodialysis. If a patient is undergoing hemodialysis, you expect the drug to be removed by dialysis. So what will be the characteristics of the drug? Good. Someone good. Low molecular weight. Protein binding. Small volume of distribution, good. Small volume of distribution means water solubility. And protein binding, someone answered yes, protein binding, good. So low molecular weight, low protein binding, water soluble, it should be water soluble drug. That means it must have a low volume of distribution. So water soluble with low volume of distribution, good. Most of you answered correct. Then, so low molecular weight, low protein binding, high water solubility with low volume of distribution. So again, we will come back to the same example, vancomycin. It has a molecular weight of 1,450 diatoms. So it's a middle molecular weight substance, 20% protein binding with a volume of distribution of 1 liter per kg. These two are okay. Okay, not this 20% protein bound is okay, not so high. It is good enough. Volume of distribution is also not so high. It is normal. So whether hemodialysis, hemofiltration, which of them will remove? Is vancomycin removed by hemodialysis? Is vancomycin removed by hemofiltration? Which of them will remove it? So again, remember, hemodialysis is a diffusion. Hemofiltration is convection. So most of you answered again. Hemodialysis, diffusion. Hemodialysis diffusion means what is the molecular weight which hemodialysis will remove? Yeah, someone answered hemofiltration. Tanya Nuzat. I don't know if I can pronounce it correctly. Miss Tanya. See, for a diffusion, for hemodialysis, less than 1,000 daltons drugs are removed. More molecular weight drugs are removed. Vancomycin is 1,450, so it is not removed. So if a patient is on hemodialysis, as most of the patients are, you do not get removed. You don't need to give additional dose. Only if you are doing hemofiltration, we need to give additional dose. Okay, if it is less than 1000, removed by hemodialysis. Our vanco is 1450, more than 1000. So it is a medium molecular weight substance, not removed by hemodialysis. So no additional dosing. If a patient is on hemodialysis, it does not require any additional dosing because it is not removed. Whereas hemofiltration, if a patient is undergoing hemofiltration, the part of inpatient or some very equipped centers, hemofiltration is removed. So you need supplemented dose. Either hemofiltration isolated or hemodiafiltration that combines both hemodialysis and hemofiltration. So in those cases, you need to give a supplemental dose after the dialysis, after the procedure. Okay. So now that was about dialysis. Now what about CRT? CRT means continuous renal replacement therapy. That goes on. It uses diffusion and or convection. You can do CVV-HD, where continuous veno-venous hemodialysis, or CVV-HF, continuous veno-venous hemofiltration, or CVV-HDF, continuous veno-venous hemodiafiltration, both. So most commonly what you use is CVV-HDF. It combines diffusion and convection. So both of them are present. It goes on for continuous. It goes on more 24. Sometimes we do it for 7 days a week, 7 days at a stage. Continuously 7 days, patient is on dialysis, 24/7. So it's a continuous process. In that case, how do you decide on drug dosing? Because hemodialysis, normal hemodialysis is just 4 hours. You just see whether patient's drug is removed or not. If it's removed, after dialysis you give. If it's not removed, you don't give. That's it. But here it's going on for 7 days together. You cannot wait for 7 days. You have to give dosing in between. So what happens is you calculate the clearance rate of CRT. You have, whenever we prescribe a patient for CRT or CVV-HDF, we give a prescription. It's not a dialysis, is not just to do hemodialysis, do peritoneal dialysis, do CRT, do CVV-HDF. Each one of them, we give a prescription. What is the time? What is the dosing to be done? What is the fluid has to be removed? How much fluid should be given? So that dosing we give, that is called clearance rate. Based on that, you decide. So conventionally, the most of the average CRTs which we use, the rate we come to approximately 25 ml per minute. So the 24 hours procedure which we keep doing, it will be equivalent to a GFI of 25 ml per minute. So it will be equivalent to a GFI of 25 ml per minute. So in that case, you open your textbook, open your FDA, or open your pharmacology books, or just open the app. You decide for vancomycin, okay, vancomycin, how much dose to be given. Consider the patient's GFI 25. No, less than 10, 10 to 25, more than 25, or more than 50. There are different criteria for GFR for each drug, right? So you consider the patient's GFI is 25, see which category he belongs to, that much dose you give. So there's no special indication after dialysis, before dialysis. You take a clearance rate, based on that, you just see if it's patient's clearance rate CRT is 25 ml per minute, then dose him as GFI of 25. Our patient's GFI clearance, you give very high, very good CVV-HDF. His clearance is about 50 ml per minute. So most of your drugs, 50 ml per minute, you give normal dosing. You don't need to decrease the dose. So you just calculate the clearance rate. Based on that, you could consider that as the patient's GFR and dose him. Okay, no other special consideration. You just need to know this. Then PD, peritoneal dialysis, again, it's a continuous procedure. But PD, the diffusion is very minimal. Diffusion convection is not so effective compared to these machines because it's happening inside the body in the abdomen. So the drug removal is very minimal. But the problem with PD is most of the CRT and hemodialysis proteins are not rushed. Albumin is not rushed. It's only the small molecular weight substances that are rushed, 1000, which I told 1000 diatons. When it comes to hemofiltration, it's up to 1000 to 30,000 or 40,000. But if you see albumin's molecular weight is 65,000, 66,000. That is not removed by these machines. But in PD, that can be lost because normal body inflammation happens. The peritoneum can get inflamed. Some point it opens up and albumin starts leaking out. So what happens if the protein is lost in the PD fluid? Along with the protein, the drug which is bound with the protein can come out. So protein-bound drugs are removed more in PD compared to other things because protein loss is more in PD. But other drugs, it is not so effective. So conventionally, PD, we don't do special calculations. We just dose the patient as a end stage in a disease. Like, some drugs have a GFI of less than 15, more than 15, or some drugs take a cutoff of GFI of less than 10, 10 to 50, more than 50, depends. So whichever the GFR, select the lowest GFR cutoff. Some drugs you have, vancomycin, we have GFR of less than 10, or some of them consider GFR less than 15 itself. So you take the lowest cutoff of GFR for that patient, dose according to that. No special consideration for PD. This GFR is calculated based on creatinine. This is calculated based on the clearance of the machine, CART, CVV HDF prescription. This GFR is calculated based on patient's creatinine. Put patient's creatinine, patient's age, use the equations, MDRD equation or EPA equation, you get the GFR, that is estimated GFR. Based on the GFR, you dose. Most of the GFRs, when we initiate dialysis, usually we initiate dialysis once the GFR goes below 10. So most of the GFR will be less than 10, will be 4, 5, 6. So based on that, you dose. So now I was talking about hemodialysis, small molecule weight substances get removed. So how much do you have to give? You suppose you use some drug which has a low molecule, you use a drug which has a molecular weight of 500. 500 molecular weight is removed by diffusion. So hemodialysis will remove it. Then you are done dialysis. It's suppose an antibiotic. You need to give additional dose or antihypertensive. If dialysis removes that, the patient's BP will shoot up. Or if it's an antibiotic, if the antibiotic is removed by dialysis, patient's infection will not come down. So you have to give after dialysis, you have to give additional dose to maintain the blood levels. You saw that loading dose curve, right? So you have to maintain that threshold. But by dialysing, all the drug is washed out. The concentration comes down. So how do you maintain the concentration is after dialysis, you dose, post-dialysis dosing. So you add an additional dose compared to normal dose on whichever day patient undergoes hemodialysis, that day after hemodialysis, after dialysis session, give an additional dose. So how do we decide how much to give? Each value depends on individual drugs. As I told in the starting, I'm not going to give the individual values of each drug. That is then all the apps which you have, all the textbook will give the dose. What I want to do, how you understand. Suppose some new drug comes, how do you decide? Or suppose you do not have some data with you, some drug data is missing. So how do you approach that? Okay, this will give you the approach. Dosing values can be by hearted or just taken from the phone anytime, anywhere. So how do you dose for a patient with dialysis? First of all, the loading dose or the maintenance dose, it depends on what we saw strategies before. And we dose for a patient with considering patient's GFR is less than 10. Because when you start on dialysis, patient's GFR is less than 10. Any dialysis, usually more than 10 we don't dialyze. Less than 10 is when we start the patient on dialysis. So already know patient's GFR is less than 10. Based on that, you give the initial loading dose or maintenance dose, whatever. Then patient has undergone dialysis. After dialysis, how much to give? That supplemental dose depends on how much percentage of the drug is removed by dialysis. So patient has undergone 4 hours hemodialysis session, HD session, hemodialysis. How much percentage of the drug is removed by hemodialysis? Into the loading dose of that drug. So loading dose is not dependent on the GFR, which I told, depends only on volume of distribution. So loading dose of the drug minus GFR corrected dose. That is, what is the dose of the drug for a GFR of less than 10? You have the chart. From the chart, you see what is the dose of you use when the GFR is less than 10. So loading dose minus GFR dose. So this again, examples. So we have a drug A whose loading dose is 1000 milligrams. The dose modification in CKD is, so if a GFR is more than 50, 500 mg, GFR 10 to 50, 250 mg. If GFR is less than 10, we use only 100 mg. The percentage of drug which is removed by dialysis 50%, that is 0.5 fractional removal. So what is the dose? What is the loading dose and what is the maintenance dose we use in this patient? Come on. Patient is not volume overloaded. Patient does not have muscle wasting. So what will be the loading dose which you want to give? Then what will be the maintenance dose you want to give? Okay, someone answered 450. That is the answer to my second question. My first question is loading dose. How much do you give? Loading dose normal is 1000 milligrams, right? For this patient, how much loading dose do you give? Is loading dose affected by GFR? Or the co-host are also Pharm D students only, right?
Yes, sir.
Even you can take the answer, ma. You don't need to wait for everyone.
So the loading dose is independent of GFR.
Yeah, good. So how much do you want to give?
550 dose in hemodialysis.
No, the loading dose. How much loading dose you want to give?
The loading dose will be 1000 mg.
Good, excellent. So you are giving 1000 mg loading dose. What about the maintenance dose? Maintenance dose, as I told you, depends on GFR.
Yes, sir.
So how much is the maintenance dose you want to give?
550 mg.
No. See, maintenance dose, you dose considering that the patient's GFR is less than 10. All dialysis patients, they have a GFR of less than 10. So you dose according to this GFR. So for GFR of less than 10, what will be the dose for this drug?
100 mg, sir.
Yeah. So we consider if patient is on dialysis means his GFR is less than 10. So you always dose based on this. So loading dose is 1000 mg followed by maintenance dose of 100 mg. You start the patient on this. Then patient has come for dialysis. He undergoes dialysis. I said this drug has a molecular weight of 500, so it is removed by dialysis. So after EHD, how much you want to give? That is supplemental dose. Okay. So you dosing, starting a loading dose of 1000 mg and GFR of 100 mg. That patient is home, you start him on this drug. Patient has come for dialysis. In dialysis, it is removed. So after dialysis, you have to give extra dose. This is the normal dose. 1000 mg loading followed by maintenance of 100 mg per day. He'll be on that throat every day. 100 mg per day, he'll be taking every day. But whenever patient comes for dialysis, he comes for dialysis 2 times per week or 3 times per week, not every day. On that day he comes for dialysis, we need to give him an additional dose, more than, apart from this 100 mg. This 100 mg is taking every day. Apart from that, we need to give additional dose. That is the supplemental dose post hemodialysis. How much it is? How much is it? So most of them have answered, it is 450 mg. So how do we get that 450 mg for others? Okay, 1 second. Just switch back. So supplemental dose postage. So fractional HD, first fractional removal by dialysis, as we saw, is 50% of 0.5 into loading dose is 1000 milligrams. GFR dose for this patient's GFR less than 10, it's 100. So 1000 minus 100, that is 0.5 into 900, 450 milligrams. Since this drug comes in 100 mg and 1000 mg, 500 mg prescriptions, we cannot make it 450, so we give 500 mg. It just depends on the drug availability. If 450 mg is available, you give 450 mg. If 400 mg is available, we usually tend to go higher on the dose rather than lower on the dose to prevent subtherapeutic concentrations. So if the drug is available in 500 mg formulation, we give 500 mg. If 450 is available, well and good. If it's not available, you give 500 mg tablet. Okay. So 50, 100 here and there is okay, no problem. So this is how we decide how much dose has to be given. So this is the routine dosing, the loading dose for maintenance 100 mg per day. Plus, after every dialysis session, we are giving 500 mg extra. That is how we decide the dosing after dialysis. Okay. So that was for hemodialysis. Now, what about CRT? CRT is done for AKI, acute kidney injury, that I told it goes for 24 hours, 48 hours continuously. So how do we decide? Loading dose is the same. Again, maintenance dose is normal annuic dose. Annuic dose means GFR less than 10. So for GFR less than 10, what is the dose for the drug? Divided by 1 minus fractional removal. This is the dose. How frequently do you give it? Again, the normal dosing interval for GFR of less than 10 into 1 minus fractional removal. This, whether you want to decrease the dose or increase the interval, depends on what we saw before. Depends on the drug half-life. If drug half-life is wide, we increase the interval. If drug half-life is narrow, we just decrease the dose. So this is what we spoke in the maintenance dosing strategies. You choose one of the strategies. So once you choose which strategy, how do you decide on doses? By these formulas. This is the actual more better formula where you see, suppose normal patient has normal creatinine clearance, you use normal dose. For CRT clearance, how much do you give? So it's normal mathematics, you do cross multiplication, right? For any formula, maths, school maths. If you want to follow this, just do cross multiplication. So normal dose, normal clearance. For how much dose to give in CRT depends on CRT clearance. So you do multiply. So CRT normal dose into CRT clearance divided by normal clearance. So just do cross multiplication, that's it. So this is how you decide on the dose. We calculate the CRT clearance, how much that CRT clearance depends on the prescription which you are given. CVHDF, we give prescribed 25 ml per minute, 30 ml per minute, 20 ml per minute, we give a prescription. That into what is the normal dose for that patient, for that drug in a normal patient, not kidney disease. In normal kidney clearance of the drug, not in diseased patients, not in CKDs. So normal the dosing in a normal patient and the clearance, kidney clearance in a normal person. So this is the dose, how you calculate. Now, how do you calculate the CRT clearance? CRT clearance determined by non, that is, hepatic elimination, which I told you. Hepatic elimination of the drug that you get in FDA studies. In that drug level you get. Yes, effluent rate is what we give. We prescribe this much of ml per kg should go per hour. That is our prescription. This is the inherent to the drug characteristics that you get from pharmacokinetics and pharmacodynamic studies, which are done, which you get, you should do before getting FDA approval. So you can get this data from there. Effluent data you get from the prescription. We give a prescription, we give 25 ml per kg per hour. So it is the effluent rate. We give a prescription, from that you can calculate this. Into sieving coefficient. Now what is this sieving coefficient? Something new which has come. Sieving coefficient is basically, all of you would have used this, what do you call atta. You do sieving before, you filter it by doing sieving. So sieving is how much of it actually goes down compared to how much of it stays back. That is sieving coefficient. How much of it is filtered down. So sieving coefficient is concentration in the diacet. So from blood, you're considering blood to diacet, because here you're considering a drug. You're going to patient a drug. It has a concentration of 100 in the blood. After dialysis, how much has come into diacet? So it was initially 100 milligrams per ml in the blood. After dialysis, in the diacet, from the blood to a diacet compartment, 50 milligrams per ml has come. So here 50 milligrams per ml divided by 100 mg. How much of it is coming here? From blood to diacet, how much has moved? So suppose 50 milligrams has moved, 50 by 100, 0.5. That means whenever you are using that drug for that dialyzer, for that pores, for that hole size, that size of the holes, this depends on the molecular weight of the drug, pore size, charge, etc. If everything is stable, sieving coefficient is 0.5 means if there are 10 molecules of the drug, 5 molecules will be dialyzed. 5 molecules will stay in the blood. Okay? If sieving concentration is 1, that means 100 out of 100 mg or 100 mg has gone into the dialysate. So everything is removed. Nothing stays back in the blood. So if sieving concentration goes towards 1, that means the entire drug concentration is removed. Nothing is left in the blood. If sieving concentration is towards 0, that means this is 0. Nothing is going to the dialysate. So sieving coefficient is 0 means nothing is entering the dialysate. Everything, the entire drug stays back in the blood. There are 100 molecules, all the 100 molecules are staying in the blood. Nothing is entering the dialysate. So in that case, you have sieving coefficient of 0. So that indicates how much percentage of drug is can go into the dialysate. So this is a common sieving coefficient for urea creatinine, 1, That means everything is urea creatinine between B12, 1. This is for normal hemodialysis. So all of them are completely removed. But if you look at albumin, I told you 65,000 is a huge molecule. Very minimal, it's almost not removed at all. So its sieving coefficient 0, it is not removed at all. Myoglobin is 17,000, beta 2 microglobin is 12,000. So all of them are in between. Some of it can be removed, some of them cannot be removed. So 50%, 60% removal, that's it. So this sieving coefficient is fixed. Again, this you can get this sieving coefficient from the pharmacokinetic data. From the FDA studies, you can get this. So the sieving coefficient will tell you how much drug, what is the chance of the drug to be removed in dialysis. So that's how you calculate the hepatic clearance plus the effluent in sieving coefficient. So again, one more example. We have a drug B here whose normal dosing is 500 mg OD with a normal clearance in a normal person 50 ml per minute. Non-inner clearance, that is a patient with CKD in dialysis, I say is non-inner, hepatic clearance is 10 ml per minute. And the effluent prescription which is 20 ml per kg per hour. Now see, these are ml per minute. Keep that in mind, ml per minute. But when you give a prescription for CVV HDF, you give ml per kg per hour. So you have to convert this. So 20 ml per kg for a 60 kg man, 20 ml for 60 kg is 1200 ml per hour. That is 1200 ml per 60 minutes. You divide it by 60, you get 20 ml per minute. So all of them should be in the same units. All calculations be careful, same units. So 20 ml per minute is the effluent rate. I say the drug sieving coefficient is 0.5. So what will be the CRT clearance for this patient? Okay, someone gave an answer of 20. Fine. How do we calculate? The non-urinary clearance is 10. Plus this is 20 into 0.5. So 20 into 0.5 is 10 plus 10. That is 20. So all of you are given the correct answers. So the theoretic clearance for this drug B is 20 ml per minute. So you dose this patient considering that patient's GFR is 20 ml. Okay. No. Okay. Now what is the actual dose you want to give? Normal drug dosing. So what is the actual dose you give for this patient? How do you calculate this now? Okay. So theoretic clearance is 20. Normal dose is 500. And the normal clearance is 100 ml per minute. Sorry, I think that I wrote fun. Take it as 100. So 500, normal clearance I say is 100. So 1000 per 100, 10 mg per day. This 20 mg who has answered correct, because I think in the previous here I mentioned 50. If you take it as 50, it is correct. But for calculation to make it easier, I wrote 100 here. Okay, so normal dose is 500 mg, theoretic clearance is 20. So 520 divided by normal clearance is 100. 500 into 20 is, okay, sorry, this should be 10,000. Again, my bad. Sorry, my bad. This should be 10,000. 10,000 by 100 will be 100 milligrams per day. If you take a normal clearance of 50 ml per minute, whoever you are giving 200 mg should be correct answer. 100 mg, it comes to 100 mg per day. If you consider a clearance of 50 ml per minute, as I wrote before, to take this formula, it comes to 200 mg. With this formula, it comes to 100 mg per day. This is wrong. It's 100 mg per day. Okay. So let me make this clear. So this is 50. This is 50. This is 10,000 divided by 50. 200. So I think this is what most of you got the answer. So this, based on these values, we get a clearance of 200 mg per day, which we have given correct answers. Okay, good. So this is how you decide the dosing on CART. We have seen about the dosing in hemodialysis. Now we have seen about dosing in CART. In peritoneal dialysis, as I told, there is no special dosing in peritoneal dialysis. Only thing when we consider peritoneal dialysis, when we are giving antibiotics. No, when the patient on peritoneal dialysis, as I told, for peritoneal dialysis, we use the abdomen of the patient itself. We don't do separate machines. The patient's abdomen works as a filter. So what happens if it gets infected? Peritonitis. In that case, we have to give antibiotics into the abdomen. So we dose the drugs in the PD fluid. Apart from that, the dosing is that GFR is less than 10. That's it. You consider patient's GFR less than 10, based on the do dose. No special dosing for PD except antibiotics. For antibiotics, because the antibiotics have to stay in the abdomen for them to act more. Normal peritoneal dialysis, we do it for 4 hours, 3 hours to 6 hours, conventionally 4 hours. But in 4 hours, the antibiotics should stay there and act. So what happens is we give antibiotic in a dose where we put the fluid inside the abdomen for 8 hours. So extended cycle. We extend the cycle. In that extended cycle, we put the loading dose of antibiotic. Then maintenance dose, how when we give is we give the long, if patient is CAPD. CAPD means daytime patient does 3 to 4 dialysis, 4 hours, 4 hours, 4 hours. In the night, patients keep one bag in the abdomen, which stays overnight for 8 to 10 hours. So in CAPD, we keep in the long night dwell. CCPD is machine dialysis, where in the daytime, you keep one single bag the whole day, morning 8 o'clock to evening 6 o'clock, you keep a single bag. And evening night, when you are sleeping, you connect the machine to the tube here. That does around 6 to 10 times throughout the day, throughout the night, it will do dialysis. So if you're doing CAPD ambulatory dialysis, you keep in a long night where this stays for 10 to 10 hours, 8 to 10 hours. If you're doing a machine-based PD, in a long day, this again stays for 8 to 10 hours. So maintenance dose, again, antibiotics should stay for 8 hours. Be it loading dose or maintenance dose. That's how you dose of antibiotic in PD. It is given into the peritoneal fluid. Into the fluid which you are infusing, we inject the antibiotic into the fluid, push it in. The dosing of each antibiotic, again, it's there in books, so you don't need to buy it. You just open and see, that's it. So apart from the antibiotics, the other drugs and all, it can be given as normal considering patient's GFR is less than 10. Even insulin was given in diabetics. Insulin, instead of giving subcutaneous, insulin was given intraperitoneally. But thing is, when they gave insulin, they saw a lot of hepatic necrosis. Insulin was causing damage to the liver. So that's why now we avoid giving intraperitoneal insulin. Some books still mention intraperitoneal insulin, but we don't give it anymore. Okay. So this was all the basic physiology, basic concepts. So just I give you for completion of today's sake, what are different drug categories which are removed by dialysis. So in antihypertensives, ACE inhibitors, all the ACE inhibitors are removed by dialysis except fosinopril. So if if a patient on ACE inhibitor after dialysis, you have to give additional dose. Fosinopril not required. Beta blockers, the water soluble beta blockers, no water soluble drugs are the ones you removed. So water soluble drugs, water soluble beta blockers, atenolol, metoprolol is removed. There's one more nadazole which is not commonly used in India. Bisoprolol is a water soluble drug, but no, there is still controversy on whether it is removed or not. That still the studies are yet to come on this. Atenolol, metoprolol, if patient is on atenolol after dialysis, his atenolol concentration will come down, patient's BP will shoot up, patient's heart rate will shoot up. So you need to give atenolol again. Or you can change over the beta blocker. You can give carvedilol or nebivolol, which are not water soluble, more lipid soluble. Among the anti-diabetic drugs, that all hypoglycemic agents. Among the diabetic drugs, metformin is removed. So usually metformin we avoid when the GFR goes, when the cat is more than 2 or GFR is less than 30. You don't give metformin. So in that case, this is not important for us because patient on dialysis, he not be on metformin at all. It's contraindicated. Among the antibiotics, patients with dialysis gets admitted with sepsis, cellulitis, anything, any of these antibiotics, commonly used antibiotics. There are many antibiotics, these are common ones used. Among the penicillin, ampicillin, amoxicillin, among then isotonium is for gram-negative organisms. Among these cephalosporins, first generation, third generation, fourth generation, all of them are removed. Ceftriaxone is not removed. Ceftriaxone and ceftriaxone are not removed. So those are the ones commonly used, which are not removed. Apart from that, carbapenem, imipenem, usually we tend to avoid. Meropenem is more beneficial. Gentamicin is removed. Metronidazole is removed. Oflox. So these are common used antibiotics which you see every day. All of them are removed by dialysis. So you need to give additional dose after dialysis, or change over the antibiotic. Other drugs, azathioprine is immunosuppressive. Patient is a post-transplant candidate, to start him on dialysis, or patient is a case of lupus erythematosus, SLE, on azathioprine, or some vasculitis on azathioprine. Patient undergoes dialysis, azathioprine levels come down. So you need to dose again. Otherwise, after dialysis, dose levels will come down, the disease will rebound. The disease will become active again because the drug concentration comes down. So you switch off from azathioprine to mycophenolate, or you redose the azathioprine again. Parcel. Post. Same thing with gabapentin or phenobarbital. So this has to be dosed again. Okay, so that was brief. I didn't go into numbers and all this stuff. Just kept a bit to the basics. So any doubts? That means basically, are you guys paying attention? Now most of you are paying attention because I got so many correct answers. Any doubts?
Participants, kindly put in your questions in the chat box so that sir can answer it.
This is the most important use of presentations. So that when you go, Pharm D, when you go into clinical trials, when you go into pharma companies, you need to put on your blank face in presentation, even if you don't understand anything. You must look active. That's the advantage of attending many presentations. So, any questions or any comments or anything you want to go ahead again?
So until we get any questions from our participants, I have a small question.
Sure.
You mentioned that in India, hemofiltration would be
okay, to put into perspective, ma'am, hemodialysis, the machine costs 6 lakhs. Hemofiltration machine costs 15 lakhs.
Okay.
One hemodialysis session per average, in a low cost setting, it costs around 1,000 to 1,500 rupees. So that is per session. Hemodialysis, you do 10 times per week minimum. 10 times per month, sorry, 10 times per month. So it's 1,500 into 10, that is 15,000 per month. Hemofiltration cost should be 3,000. So it's 30,000 per month, double the dose. So it's only, patients who are affordable or very established corporate setups. Only some places we keep the machines. And if you go into proper studies per se, theoretically, hemodiafiltration should be beneficial in removing all the middle molecules. Beta-2, yesterday, the last meeting, someone asked about beta-2 microglobin amyloidosis. So theoretically, the beta-2 microglobin should come down, so all the side effects and the complications should reduce. But when you come to actual studies from different centers which have done hemodiafiltration, comparing to hemodialysis, they have not found any much difference. So that's why it's still not widely accepted. Unless the patient is affordable, you just give him an option that this has theoretical benefit. If he wants, he can opt for that. There's no harm in doing it, but advantages are still not established. Theoretical advantage definitely it is there, but once you come to actual clinical studies, it is yet to be established. So cost factor and the actual evidence based is not so strong. That is what you asked, or anything else, ma'am?
No, sir, my question is answered. I just wanted to
Okay.
know that in what cases in India will hemodiafiltration be
Hemodiafiltration, same thing, the medium molecule, but
Yeah.
main difference for you to choose comes when you in case of poisoning.
Yeah.
There are different types of poison. In India, we don't know you can get any poison anywhere. So you go into the poison's details, ma'am. You go into the molecular weight of the poison.
Okay. Yeah.
So
Yes.
that decides. If molecular weight is less than 1,000, you know that dialysis is going to come, provided it is water soluble and just protein bound. If it's not water soluble and it is high protein bound, none of the things will help. It is water soluble and protein binding is less. So that means that you can do some intervention for that. In that case, you decide if the molecular weight is less than 1,000, hemodialysis is sufficient. If the molecular weight is 1,000 to 20,000, in that case, you have to go for hemofiltration.
Filtration. Yeah.
So poisoning is the only one where you decide. Poisoning or drug toxicities. Some drugs. Drug toxicities, not the drug dosing, drug toxicities. Lithium poisoning, hemodialysis. Lithium poisoning is commonly we see in psychiatric patients. They are in lithium drugs. So lithium molecular weight is very, I think 400 or something. So in that case, I don't need to go for hemofiltration. I can just do hemodialysis. Good enough.
Yeah.
So these toxicities or poisonings are the ones we actually need to think. Otherwise, just patient comfort.
Okay, sir. Thank you.
All right.
Sir, I had a question, sir.
Yeah, ma'am.
Sir, for colistin dosing, sir, for loading dose, I had read in some article that there was a particular formula, like. So, do we actually follow that even for loading dose? Because it had mentioned two different formulas, and one was for loading dose, and one was for the maintenance dose.
I think I saw in one of your posts, ma'am. I think I don't know it's Instagram or Facebook. One of your posts, you have mentioned this dosage of colistin. If you see that, loading dose is equivalent throughout 9 million units throughout. The loading dose depends
Yes,
on the
sir.
volume of
Sir,
distribution.
but then later I went through some articles, no? So there was an article which suggested that the loading dose should be it should be changed according to the GFR, like.
No, loading dose, as I told you, it depends on volume of distribution. Based on GFR, what you do is you decrease the dose extent. Suppose you give 9 million units. Individual patient, suppose I give a hypothetical number. You are given a 9 million units, and suppose I need to achieve a target concentration of 30. With 9 million units, I'm achieving a concentration of 50. In that case, what I can do is the next dose I can give at a later day. Instead of giving after 12 or 24 hours, I give it after 36 hours. Or the next dose, instead of giving 3 million units or 1 million unit, I give half of it. So loading dose, you can keep it the same. So you have studies where you can get this loading dose, what concentration you can achieve in the blood. Based on that, you can decide on the next dosing. The next dosing you can adjust. You do not change the loading dose. Thing is, you keep changing the loading dose every time. First thing is, theoretically, it is not valid. Second thing is, colistin dosing or any drug dosing is already very confused in hemodialysis. You don't want to put too many complicated formulas in each and everything. So try to make it as simple as possible. That's what we do. We try to make it, most of the times, we try to keep a single number for something. We try to fix one aspect. Second aspect, we try to adjust. If we keep adjusting both the aspects, things become a bit more complicated. That's it. Dosing, see, loading dose can be changed in colistin. Some people do change colistin dosing. But thing is that makes things complicated for us. Simple as that.
Yes, sir. So is there any particular guidelines for colistin? Like, because like all the journals have different dosing mentioned in it.
I have been telling you, for all the drugs, first always go to FDA, ma'am.
Okay, sir. Yes,
FDA will give the entire data. And that cannot be contested. Wherever you are, that is evidence-based. We cannot suppose tomorrow I give question for some patient, some side effect happened and someone sues me. In the court, I cannot quote a journal article. It is just someone's study. FDA is established data. No one can question that. So you have your different pharmacopoeias, right? So FDA data, all European data, Indian data is not so established. You can use FDA data or the European data. That is established. Journal articles, you think about that only in certain special conditions. Suppose a patient has come where, suppose I have a patient now who is not able to get 9 million units of colistin. He is not able to buy so much. So then that is the case. I can think of all these alternate strategies. Or I do not have availability of 9 million. I'm working some PHC. I do not have a dose of 9. I have only dose of 3 with me. Instead of giving 3 different vials, what I do is that is when I put these dosing strategies. That's all individualized my own personal experiences which I use. So where I cannot follow the protocol, I deviate from the protocol and I try to do the best. But once if you go evidence-based medicine, if it goes into a court of law, again it's good. I'm in soup. So always try to fix with FDA. Other things, keep it to journals, keep it to study. If you're doing anything as a part of study, if you want to actually, you're doing a study on colistin dosing and the concentrations, then you go for all this after your proper ethical committee protocols, ethical committee permission. That way you're safe. Okay?
Yes, sir. Thank you so much, sir.
Welcome.
Sir, there was one more question from my side. Sir, if there is a digoxin toxicity case, sir, so will we prefer giving DGFab or the patient will be taken on dialysis?
Digoxin, we prefer DGFab because the digoxin immovable dialysis is not so common. The volume of distribution is very high. Lipid binding is high. So digoxin immovable dialysis is not so great, man.
So, sir, the results with DGFab are better, no?
DGFab is better. Only thing when we consider when we actually have last result, we do hemodialysis. Suppose DGFab is not available. Suppose I'm in a state, I'm working in a city where DGFab is not available. So what happens is, suppose I'm giving hypothetical numbers, okay, not actual numbers. Suppose there are 100 milligrams of digoxin in the patient's body. Out of 100, 99 or 90 milligrams is in the lipids, in the tissues. 10 milligrams in the blood. I do dialysis for 8 hours, 10 hours. I am removing only 10 mg. The 90 mg is still toxic. So suppose 20 mg is safe. So still 90 mg is toxic. In that case, what I do not have DGFab available. I do dialysis. This 10 mg is removed. So what happens now? The tissue concentration is 90. Blood concentration is 0. So what happens? From the tissue and the 10 mg, we move into the blood. Once this 10 mg moves into the blood, I do dialysis again.
Okay, sir.
So this way, this 10 will again come out. So next here in the tissue 80 is left. From that 80 again 10 will move out. So this way slowly that rebound will keep happening and slowly bit by bit I can remove. This will be the last resort. That is actually, you actually give DGFab. But if you have no other options, patient is dying in front of you, want to do whatever you want, you can try this. Either you're moving 1% or 5% or 10%, you keep doing it repeatedly, you have some use. Provide the patient is alive for so many hours. That way you can use. But theoretically and ideally not good, not feasible.
Yes, sir. Thank you, sir.
Right.
So one participant has asked a question. Is the maintenance dose based on GFR? Like based on GFR, maintenance dose is selected.
Yeah,
like that is what she has asked.
GFR, see, some drugs do not need a loading dose.
I think so that may be for the colistin question because she's not mentioned for which drug or something.
All the drugs. And this loading dose, maintenance dose is not for other drugs. Only some drugs we give loading dose. You have levetiracetam, anti-epileptic drug. You have phenytoin, you have valproate. Anti-epileptics we give loading dose. Suppose you have an antibiotic, simple penicillin or ampicillin, we don't give a loading dose. Amoxicillin, carbonic acid, we don't give a loading dose. So loading dose depends on again the characteristics. If you want to achieve a concentration very fast, you give loading dose. Otherwise, maintenance dose is enough. Patient with a long half-life, you give loading dose to maintain the heart pressure. So if a patient has a loading dose and maintenance dose, again decide on GFR. Maintenance dose depends on GFR. Some drugs do not have loading dose at all. It's just fixed dose. 500 mg BD, 500 mg TID, 500 mg OD. It's a fixed dose. There's no concept of loading dose. In that case, you decide again on GFR. So whatever you're going to do throughout the day, everyday dosing is always depends on GFR. Single shot dosing, loading dose, if it is present, that depends on volume of distribution.
Yes, sir. Sir, and one more question from our registration form was, if the volume of distribution of the drug is low, then how will you manage the dialysis in such a patient?
If volume of distribution is low, means there is more chance of the drug to be removed. So first I decide it's a toxicity or it is just a drug effect. Suppose the patient is drug toxicity, I want to remove it more. I do more dialysis. Or suppose patient is on atenolol, low volume of distribution, and it is removed by dialysis. So what happens if patient is on atenolol? Dialysis patient is a hypertensive on atenolol 50 mg OD. He comes to me for dialysis twice a week. What I do is after dialysis, I add an additional dose, the supplemental dose which we calculated before. After each dialysis, I need to add a supplemental dose. Or better still, if I have other options, what I do, instead of atenolol, I start the patient with carvedilol, which is lipid soluble, not removed by dialysis. So we have alternate options, we go for alternate options, which just change the drug. If no alternate option is available, then after each dialysis, we add an additional supplemental dose, which we calculated before. This. So this is how you calculate the supplemental dose. After every dialysis, how much to give depends on this. Okay.
Yes, sir. So thank you so much, sir. And the last question from one of our participant is, how do you calculate the UF that has to be removed in a patient with heart failure, in a CKD patient with heart failure?
Okay, height filtration, the commonly used thing which we use just clinical judgment. We know how much patient's weight has gone up compared to last time. If a patient is on dialysis dependent patient, then we obviously after every dialysis we measure the weight and we fix something called as dry weight. For each dialysis patient, we fix something called as dry weight. Dry weight means that is the weight at which patient we have no additional fluid. Suppose patient's dry weight is 50 and now patient's weight is 55. That means he has 5 liters of extra water in his body. That has to be removed. We do not remove 5 liters at a time. We remove 2 or 3 liters per session. That is in case of dialysis. But in case of heart failure, they suppose creatinine CKD, creatinine of 2 or 3 does not require dialysis for the CKD. But patient has refractory heart failure, bloated up, we need to remove water. In that case, again, say the thumb rule is we do not exceed water UF more than 13 ml per kg per hour. That beyond that it is damaging. So 13 ml per kg per hour. If you take a 60 kg man, approximately 750 ml per hour. If you want to be safe. If patient is very sick, patient has come to acute pulmonary edema, in that case we remove. So it's just clinical judgment based on each patient. How much fluid is present in the body? If you want a objective, you want an objective assessment. There's something called as bioimpedance, where minor current circuits are passed to the body. It will give you the amount of protein, amount of fat, and amount of water in the body. It will give you the amount of extra water in the body. So then you get to know how much extra water has to be removed. Based on the amount, suppose you want to remove 5 liters or 10 liters, based on that, you adjust the dialysis sessions. You want to remove 2 sessions, you want 3 sessions, you want to remove 4 sessions. That is individual call, depending on individual patient's BP, how much is it tolerating. That's individual call. That depends on each patient. There's no standard thumb rule for that.
Yes, sir. Thank you so much, sir. Kuldeep, I would request you to propose the vote of thanks.
Sir, I have one last question.
Sure.
Yeah. So I had read somewhere that in few patients it was observed that after chronic or repeated episodes of not episodes more
sessions of dialysis,
hearing abnormalities were there. So if that occurs in patients, how do we manage that and how do we prevent it in the patients?
The thing with if a patient on dialysis comes with hearing abnormalities, the first thing I consider is the drug effect rather than dialysis effect. Hearing abnormality occurring because of dialysis is not so common. It's more likely most of our dialysis patients are on loop diuretics, Lasix, furosemide, torsemide. And suppose normal walking, talking person, non-CKD person, we give you furosemide is 10 mg, 20 mg or max 40 mg per day. But if the patient is dialysis dependent, we give them furosemide of 200 mg, 300 mg per day.
Okay.
So that high concentration for that urine to produce, because CKD is not working, the kidney is not working. We need to give that high concentration. Now, when you're giving that high concentration, the ototoxicity also be so high. So first thing I consider is loop diuretics. Second thing is the cause of the kidney disease rather than kidney disease. The cause of kidney disease, IgA nephropathy. The IgA nephropathies or there's some genetic disorders like Alport syndrome. These syndromes are associated with hearing loss. These are the things which I first think of. Hearing abnormality only per se because of CKD is not common. First thing, if a patient has hearing abnormality on CKD, not on any of these drugs, first thing I have to consider is stroke. Okay. Local disease can happen, but it is not common.
Okay, so thank you. With this, we end our question and answer session. I now hand over the session to my teammate Kuldeep.
Thank you, Yamini. Thank you so much, sir. On behalf of Pharm D Community, I would like to thank you for accepting our invitation and delivering such an informative session. With the years of experience that you have and the depth of knowledge you have on the topic, it was really a very informative and concept clearing session. I would also thank you for sparing your valuable time and clearing the doubts of our participant. Thank you so much, sir.
Welcome.
I also thank all the participants who have joined us for the meeting today. Thank you so much, everyone, and a happy Diwali. Thank you.